So this session, we've got Shahin Shah back in the house with us to moderate this panel discussion. The panelists include Joe Zakaria, the VP of Strategy and Finance at Nitera, Todd Larson, consultant for workplace and public safety for Honor Health, and Terry Coates, senior VP and the CIO of the Guthrie Clinic. All right, so I'm going to turn this conversation back over to our moderator.
All right, welcome everyone. So I'll have the panelists join, and while they're popping on their screens and turning on their audio unmuting, I'll get the conversation started. So what I really love about some of the groundbreaking work that Natera is doing here in the contactless monitoring space is that even as a few years ago, guys like me, I'm in the medical device world. I've been building medical devices for many, many years. And we've always heard from our hospitals and health systems that we'd love to put in more monitoring. We'd love to put in more information, but who's going to go review all that data? Well, that problem is much more solvable today than it was 5 years ago. So this idea of contactless monitoring, believable practical data that's coming in through a variety of different sources, which now a high impact AI can actually review and do things on behalf of patients, becomes even more important to try to embrace because of our hiring challenges and because there are so many issues with getting resources in place today. So with that, let me get each one of our audience members, our panelists, to introduce themselves for the audience, and then we'll jump into questions. Terry, let's go with you first.
Hi, good afternoon. I'm Terry Coutts. I'm the Chief Digital Information Officer at the Guthrie Clinic. I'm a nurse by background. I've been here for about 8 years now, and in this role a little over 3. And we serve both New York and PA in a very rural environment across about 10,000 square miles.
Awesome. Todd?
Todd Larson with Honor Health. I've been there about 10 years, coming off a career in law enforcement as a first responder. And my current roles are to run our Innovation Lab project and our Network Operations Center, which originally began with a workplace public safety focus, but frankly, the clinical operations and the actual integration of all hospital operations has far surpassed that. So really on to complete integration.
Yeah, that's a very unique background that you have in that first responder space, especially sitting where you are. So that's fantastic to hear. Joe, quick introduction, and we'll jump into questions.
Thanks. Joe Zakaria. I am a VP of Strategy and Finance in Natera. I am approaching 8 years at the company, and I work closely with Terry and Todd. So excited to have this combo.
No, I love it. So yeah, health at home and home care has a special place in my heart. I started a company a few years ago building tools in that space. And I know how hard it is to get, so hospitals and health systems already have it difficult because everything happens in a difficult to manage environment. But now take all of that difficulty that you have dealing with patients and now spread it around everywhere, right? That's what we're talking about in the real world. So Terry, walk us through a little bit about what Guthrie Clinic is doing with your hospital at home strategy. What is different about that strategy versus how you manage care outside the home? And then talk just a little bit about what this contactless monitoring means to you in your healthcare settings.
Sure. So like I mentioned in my introduction, we serve about 10,000 square miles in a very rural environment. We cannot have the traditional hospital at home from the sense of regulatory requirements. We don't have the food service availability, those kinds of things that you need to meet those requirements. But what we're trying to do is really push the envelope all the way to the borders of those to see what can we do, and we're calling it care in place. So we want to care for our patients where they need it, how they want it, and sometimes that's care in the home, sometimes that's care in our facility, and sometimes that's care in like a long-term care facility. And we really feel that by doing that, that's going to help us shift our care models to be a little more proactive in managing the care setting. It should help us with our workforce, but also, more importantly, it should help us engage our patients to care for their disease sets and be in the setting that they want to be, which is home. We're starting with Natera in our long-term care facility. And we've picked some very specific metrics on how we want to use the contactless monitoring to meet our goals. That is their home setting for those patients. We want to make sure that we prevent them from coming into the ED where possible, that we can enhance maybe understanding little minor changes to get the care earlier, so maybe they don't get septic, or maybe they don't have an admission. And ultimately, the finances will follow that, and it will have positive outcomes to our margin. It will help us make sure that we utilize our resources better in the ED and make sure that the people who are coming to the ED really need those resources. But it's really about caring for those patients in the setting that they are living in, and making sure that they don't have fallouts, because in that care setting, we don't necessarily have, vital signs that are on a regular basis and things like that. We want to expand that into our other services like home health and maybe even hospice. And so looking at how do we use the same monitoring to get to them in the time that they need them, not because they have 3 visits scheduled for the week, but how do we know that those minor changes is Tuesday they actually need the visit, not Wednesday when it was scheduled, or vice versa. And then for our hospice patients, making sure that we get that visit in the timely manner that's around the billing requirements. So we have a lot of things that we're looking to kind of enhance using this technology, and we do feel that it's going to really change how we deploy our resources, how do we utilize our resources, but ultimately how we care for patients.
That is fantastic, Terry. So do you have some numbers that you might be able to share with respect to how big, like, is it 2%, 4%, 5% of your population that you're able to do this kind of work for in your rural communities?
So, I mean, we're starting out very, so it's all about trusting the data and making sure that we have good processes around that. So we are starting at very small. We are looking at reducing the amount of referral or utilization into our ED by our long-term care facility. So starting within our own facility, but we also want to push it out to our community partners as well, and reducing that by 10%. We also want to make sure that we can not only do that on the forefront where they're coming into our facility through the ED, but also when we're getting them out. So when they need rehab services or home health services, how can we utilize something like Natera to get them home and get them in an environment that they want to recover in, without waiting on, can we place them in another facility? Because we all know that that's very difficult, because those facilities are backed up and don't have the resources in the same way that we don't. And so that, pushes out our length of stay. So we're hoping to increase that referral base into the home by 5%. We started out very small, but this is an OKR in our system goals that we are measuring against.
Yeah, and just so I interviewed John Halamka, who runs Mayo Clinic's hospital home platform program, and he's mentioned something surprising in that interview, in which he said that they were doing almost between 8 to 10% today of many of their visits that can be done. And of course, this is a world-class institution, just like Terry, you're at. So if you look at their numbers, John believes, and if I'm not mistaken, if my memory is serving right, he believes that that could be in double digits, like the total population of Mayo can be done in double digits. And that's for high acuity, research oriented and that kind of environment. So my guess is that you guys could even, Terry, and I'll bring in Todd here to explain a little bit about the same things that Terry is doing. What are you doing? And maybe talk a little bit about how prevalent this might get over the next few months and years.
Yeah, so we are in the very early stages, and what we're looking at are gaps. So what are gap areas that we could utilize this type of technology for? So really 2 areas, and the first is actually in the acute care setting, but we're looking at deployment in the emergency room waiting area, where we have deterioration issues, and we have had bad outcomes like many hospitals have around the country, because obviously many emergency departments are overloaded. They're struggling to keep up. They have long wait times, and you have a lot of left without being seen. That's obviously a measurement that many healthcare organizations are very concerned about from the emergency standpoint. So we're looking to deploy in a de-identified setting initially, where patients come in, they have an initial triage. There might not be a bed or a space available, but we're a little more concerned about their rhythm. We're a little bit concerned about their patterns. We're a little bit concerned about their vitals. And so we're going to have them sit in a specific chair that's monitored and can alert and can notify staff and triage. Right now, I think most hospital systems are somewhere between 40 minutes to 1 hour, where they go out in the ED waiting area and they round and they do this manually. So we're looking at, well, can we do this using devices such as this to capture that information, send alerts, and we can either mitigate or hopefully avoid serious deterioration issues in the ED waiting area. And then a second area we're examining right now is working through a project with our NICU and our OB areas, where a lot of times family members, whether it's cameras and there's other systems out there that NICUs deploy, and families take this baby home and they are at like incredible levels of stress. And so we're looking at deploying this, and can they take this device home with them and continuing monitoring their vitals, doing all of those things, because many of these parents are almost exhausted from that care of that NICU patient. And when they do go home, they really get a sense of safety and satisfaction, knowing that there's this continuous monitoring going on. So that's still in exploratory phase, and we're working through that. But we see this as something in our OB area that could be a take-home or home health type device. Those are just two examples of what we're currently deploying. And there's some others, and Joe can obviously talk about some of his initiatives as well.
Yeah, I mean, so I am just fallen in love with both of those use cases, because if you think about it, the de-identified use case can be deployed so quickly that it doesn't have to impact any of your processes and procedures dramatically, right? You don't have to worry about registration and all the connections and everything else. Hugely important and very, very smart way. The other thing to think about, and this is a good general lesson for all of us in the audience, is that anytime you want to deploy digital health technologies, especially things that are FDA cleared like Natera is, do it with pediatrics or NICU, because one, they need it, but more important, they're willing to accept it. They're young parents who will pay attention. If you give them instructions, they actually follow their darn instructions. So now, having said that, instructions mean a lot. Joe, catch us up on these two use cases. Where are you guys seeing the most success in these types of use cases or beyond? And how hard is it to deploy this stuff? And who do you have to retrain, and who do you have to newly hire, et cetera?
Yeah, so I mean, I think the whole goal and the way we're trying to approach this is that there is no need to retrain, right? There should be a seamless integration of the type of data that Todd and Terry are used to getting and their staffs are used to getting, but just in a less friction or labor intensive manner, right? So they're used to having clinicians come around, check vital signs, input that into the EMR. Our goal is to do the same thing, but passively. I've had the luxury of being in both command and control centers that Terry and Todd have rolled out, and it's a really impressive tool when you see the staff there and how far they're able to reach into the various pieces of the hospital system to get insights and to help do more with less. And we think that technology can be a really incredible part of that for the population. The other piece is, we don't know what we don't know. And I think part of what we're doing with Terry in the long-term care and the skilled setting is to get that level of comfort with the data and the trust and build the processes in place to roll it out across their entire ecosystem. And then with Todd at Honor, what we've been talking with, and I love the NICU one. It was one of my favorite visits because it's such a serene environment, and we had the ability to talk with these truly passionate caregivers. But the family members, to Todd's point, when the parents take the kids home and they're used to the first 6 months of hearing all the dings and whistles and cameras and talking to clinicians, and all of a sudden it's great, we've done our job, you're going to take your baby home. There's that, oh my God, but there's nobody watching them anymore. And what we're trying to do is help them bridge that gap where they can still have that level of comfort and the clinicians can still see that data because it's remote and it's contactless. So it's an extension of that environment, but without being very burdensome. So our goal is to be as seamless and frictionless as possible, integrate into existing workflows with our device, and really just be a different way of collecting the same information that the clinicians are accustomed to getting.
And so, Joe, let me ask you a little bit harder question, which is,
Yeah.
there are people who would love to see this kind of equipment, but you get a lot of objections. So objections all the way, like that's why I brought up the training and the retraining and how do you install it, et cetera. What are a few of the common objections that you get, and then how you react to them? And then I'd love for Terry and Todd to say, were they questioning this technology initially and now they're on board, or hey, we were on board initially, and here are some of the problems and challenges we're seeing. So let's get to the practicalities of reality. So tell us, Joe, what are the biggest objections that you see that you can easily overcome?
Yeah, the first one is the workflow piece of it, which is, well, what are we going to do with all of this data, right? And our goal is not to write vital signs into an EMR 10,000 times a day. If it's a Q4 patient, a Q8 patient, it's to basically write that the same way a staff would come around and collect that information. There's the accuracy, which obviously we've gone through the FDA approval process for it, and the data speaks for itself. And I think people are pleasantly surprised when they see how reliable and accurate and continuous the information is. The other one is just it's something new, right? And when you have forward thinkers like Terry and Todd, and they're willing to go out and do this, and they're excited about it and blazing a path. There's other people who have the nobody ever got fired for choosing IBM mentality, which is, why are we going to change what works? And our goal is to not really change anything except free up time while still giving you the valuable insights. So we get less and less pushback now, I think, in the last particular 18 months post-COVID, when there's been that real understanding for what do we need and how do we do this better and less expensive. The barriers have come down, and the willingness to adopt a new technology has gone up. The installation, we have a team, they've done 20-something thousand of these installs. It's really, really seamless. When the IT people and the maintenance people are part of the program, and there's buy-in from the top of the food chain, it makes the process easier. So a lot less pushback than we used to get, but I think the big thing is just the change in how is it going to work, and our goal is to just make that as seamless as possible.
Yeah, and that's really what I wanted the audience to hear. Is a lot of people are naysaying, not for being Luddites. Like, it's not like they don't like technology. They just think it's harder to do this. But the opposite is true, right? It's much easier.
Very simple.
Yeah, easy to do. Now, there's also part of this which most people don't think about, and that is, if you are in an area in which one or two or hospitals have Natera, and you're trying to hire somebody away from that environment into your environment, which you don't have automation, where you don't have contactless monitoring, those nurses, those doctors are not coming to your organization. So you have to have a baseline that grows, right? Go ahead, talk about that.
No, I was going to say that, that we are striving to have that sort of data and to prove that out. We believe that we will get there. We're too new to really say we've seen less turnover and whatnot, but we think that once it becomes part of a workflow and a staff recognizes that they don't have to wake somebody up and get yelled at 10 at night to take their vital signs anymore because it's being done in the background. I think that's sort of one of those quality of work elements that's going to really drive retention.
Awesome. So Terry, talk about that quality of life that Joe was just mentioning. Have you seen it yet? And what are kind of things that you've learned now doing the pilots and doing the smaller rollouts, where you're telling Joe, hey, I need this new feature, I need that new feature? Because I know they're able to adapt pretty quickly. Even though it's an FDA cleared device, they actually move pretty quickly in the market. So what are you suggesting to them, and what are you seeing in your environment?
Yeah, I mean, we're fairly new into the Natera deployment, so we haven't necessarily seen it with Natera, although we have high expectations. I do think that we have seen it in some of our other AI-enabled virtual care models, right? And so I think if you start with the idea of what problem are you trying to solve, you have some measurable outcomes that you're going to use to drive how you pivot, and you adjust to that, you're going to see the outcomes that you're looking for, and also maybe some unintended ones that add an added benefit. I know for us, our nursing retention has definitely increased with the use of these kind of virtual care models. And I do think that we're going to see that in this environment as well. We have, a really high stressed area that's, has a large staffing shortage. And if you take one person out to transport that patient to the ED because now they're sick and they need care, that is one less person that provides care on the floor. And so that's, or in the long-term care facility, or if you can't use the data to get to the right place at the right time, and they're traveling all over the place, and now they have to go back out again, that's additional work, that's additional burden. So I do feel that we're going to see that. Of course, we're tying all of our outcomes around, or see around the patient, but the caregiver is definitely a big piece of this. And you have to really start with, what are you trying to solve? Todd's use cases and my use cases are very different. That doesn't mean either one of us are wrong. It just means that we understand our organization and what we're trying to use the technology to drive innovation, enable care. So I really feel that, it just depends. But we have definitely seen it in other areas already. And I'll hold Joe responsible for doing that with Natera as well.
That's right. And speaking of organization, one really cool thing that happens when you install tools like Natera and contactless monitoring, additional automation, is that you can start recrafting your strategic plan in terms of what service lines you'll be able to handle, what service lines you could do in the future that you could not do in the past. Do a little bit of open brainstorming, pretend nobody's listening. What are the kind of cool things you think you can do with your organization in the next few years when you have tools like this?
I mean, I think the way that these sensors are developing, the way that AI is being kind of folded on top of it, and machine learning with algorithms, I think the advances are going to allow us to do a lot of different things. In our region, you could drive an hour and a half to see a specialist. And telemedicine has been around for a long time. That's not the answer, right? So it's just not the video kind of consult that you would get. It's really about making sure that you have the right data to drive the right decisions at the right time. And I think tools like this can bring that to us. Now, of course, some of the things that you asked about with Joe about what's the naysayers, a lot of people are afraid of that data because now they're responsible for that data. And so you have to take considerations into that. But I do think if you have a process to kind of drive or govern that data to escalate in a way that can be actioned, that's where the value is. And tools like Natera can help us with that. And I do think as we get more down the line of kind of preventative care and away from fee for service, this will help us in an affordable way be able to do that, where we can care for more patients in the home. I think bricks and mortar are going to not go away per se, but I think who uses those are going to change, and we have to kind of address our mindsets differently. I mean, I can see a lot of different things happening in the home. Even, we have a paramedicine program, but we can expand that paramedicine program to make sure that we can deliver service to them instead of having them come to us. You think about cancer patients, people who don't want to get exposed to additional disease sets. I mean, you have a lot of opportunity there if you can develop the right processes around it.
No, I love those ideas. Todd, tell us,
Yeah.
start with maybe talking about the quote naysayers. What were the early objections that you saw that you had to overcome? And then how quickly did that change to more positive affirmations towards technologies? It doesn't have to just be Natera,
Yeah.
but these automations.
Agreed. I actually wrote down what Terry said because it is the number one thing that came up when and I don't call it naysayer. I get your term with that. I totally from a layman's term, I'm with that. But risk concerns, legal concerns. I actually wrote down, Terry, we said, now we have this data. That was said to me multiple times through this process. Now we have this data. We're now liable for this data. And my general answer, and I know it's a cultural thing, my general answer is we've always been responsible for the patient. We will always care for our patient. So why would we not want to have the most data to provide the best care? And I think that from a patient care standpoint, it gives us opportunities for whether that, in our case, with an early intervention on a deterioration, or with Terry's case from the home setting where they're not getting this monitoring at all without it. My theory is now that we have this data, we can provide better care. So I do think organizations need to understand that that's a common, whether it be legal, whether it be risk, whether it be your quality division, whoever these are, they're going to ask that question, does this layer an added level onto us? And, just from my role and my position, mine was always, let's get the most information about our patients as we can. Let's provide them the best care that we can. And if we can do that with real-time monitoring, then let's enhance their care. So that is the way I've looked at it. I used the emergency room example with our case as right now we're collecting no data on them sitting in the waiting room other than once an hour when someone goes out and rounds. I'd much rather collect that data, get an alert, and have an immediate intervention than the family member coming frantically up to the ED, triage counter or help desk saying, my husband just passed out in the chair over there. Oh my gosh, I need some help. I think we as an organization look much better in the caregiver space if we already had that alert and we're already out there helping them. So that's one aspect. The second aspect is staff. So nurses, to me, are brilliant. They will work around any solution that doesn't work for them. And I mean that in a positive way. Nurses are efficient. They're there to deliver care. They are burdened with so many responsibilities that if something that we're layering on, and it could be this, it could be any other technology, I'm just using it as a term. If we're layering something on and it's not a quality initiative, it's not enhancing their role, it's not lessening the burden on administrative time, it's not giving them more time with the patient, whatever that could be. I have seen for the last decade, a common nurse phrase of, who thought this was a good idea? Who brought this here? And often the nurse will work around it. And they're still going to provide great care. They're just going to work around anything that is not helping or enhancing their role. So the last thing I would say with the naysayers is we're focused right now on familiarization. When we're doing this de-identified version in the emergency rooms, we're, put it in our nursing break rooms, have it there on a laptop. They sit in the chair. They see how it works on themselves. They talk about it. They talk about it on the floor. They're playing around with it. Open lab times, open time to come in the sim lab, just letting them from a visual, audio, and tactile, letting them touch it, play with it, feel it. And I think the other side of it is it's okay that a nurse comes in and sees the device, sees what the vitals are, sees what it says, and still uses their stethoscope for a while because they want to build trust. That's okay. I think that's totally okay. But over time, I think the key factor is to understand there is a huge change management process with this. And I think you need to have the nurses involved from the start because they're brilliant and they know their patient care better than anyone. And so get them involved early, get them use cases, let them play around with it.
Yeah.
And one thing I'd love to just add on this is I think that as we our vision for the company and what we're trying to do is move in general to a proactive care model versus a reactive care model, right? And the reactive care is when things have gone wrong. And, in Todd's situation in a waiting room, whether it's the person who came in to be treated or it's the family member who brought them there, I'm sure the folks at Honor don't care who they're going to help as long as they're helping the people that are in need. So our view of this is that well, now we have all this data, so we have to act. Well, if you're not continuously acting in a reactive manner, you have more time to support people earlier without adverse outcomes. So we kind of flip it on its head and say, well, you're not going to have to worry about this stuff, hopefully, if we're in a position to give you data before things get bad, and sort of rank order triage, with quantitative and qualitative metrics to support it.
That's right. And just to catch everybody up, Todd, Terry, and Joe are too nice to say this, so I'll say it to everybody. Anybody who says that, oh, we have new data now that puts us more at risk, just doesn't understand the legal system in the United States at all, right? It doesn't matter what data you have or don't have. You're either negligent or you're not. And the only way you will ever be shown as non-negligent is that you collect data, right? There is no opposite scenario where you sit, like I've sat with in hundreds of hours in front of lawyers on a witness stand. You're being asked what happened. It doesn't say, oh, did you have the data and did you prevent it? No, nobody asks you that. When you make a mistake, you made a mistake because you didn't have data. And that's the easy way to understand that without, and by the way, the reason why we make nurses today do insane things like every 2 minutes or every 15 minutes, every 25 minutes, take a vital and write it down is because anybody who doesn't do that is negligent, right? That's what happens when you go to court. When you get hauled into court and you're not doing any documentation, you're called negligent. 2 years from now, 5 years from now, when everyone else is digital, anyone who is not digital would be called negligent, right? So this is just a matter of where things stand. And anybody who uses that term that says, oh, I've got new data, now I have more responsibility, just doesn't understand risk and doesn't understand legal, which is, our nice friends at Natera and Todd and Terry will not tell you that, but those are foolish statements. Now, having said that, they're still real. They're practical concerns. So Joe, as you heard from Terry and Todd, on their current use cases, I think they're going to do a fantastic job. They've got great ideas of the use cases. Where are you guys heading? You see the state of the art today. What does state of the art look like a year from now, 2 years from now, where these guys can skate to where the puck is going?
Yeah, what we're trying to do as an organization is not only give, the vital signs that we talked about that we're accustomed to all using to deliver care, but there's also, a behavioral aspect of what our system can do. So it's things like movement in bed that we're working on, or the amount of time somebody may get in or out of bed. So that provides a contextual layer to what's happening, so we can have more of a holistic picture of what's going on. Somebody may not have a change in vitals, or it may be subtle. But if we say, hey, this person also got out of bed 5 times in the middle of the night, maybe they have a UTI infection, right? So there's these behavioral characteristics that we are trying to layer onto the quote unquote quantitative vital signs that we're delivering, which will hopefully allow us to give a more holistic picture. Now, I think one of the things that we're hoping with Terry and Todd is to also get that clinical workflow lens to say, what is this data doing and how is this helping you improve care? And then smarten the way our system interacts with their existing workflows to give them a more full-rounded picture of the environment, and then co-develop feature sets that are meaningful to their clinicians based on what we can and can't take, and then also have our system be a two-way interaction with EMR systems where we're absorbing the historical information from the patient. This way we can sharpen our pencil in the deliverables that we have from an alerting and notification standpoint. So I think we're tip of the iceberg here, but we're going to need to partners like Terry and Todd and their organizations to really help us dial in on what our information can deliver and how it can impact the point of care.
Yeah, and speaking of tip of the iceberg, Joe, your data seems like perfect for real world data, real world evidence, RWD, RWE.
Yep.
In clinical trials. Can you speak to, is anybody using you for that, and what benefits do they see?
So we've talked with a couple entities who are looking at twofold. One would be something like decentralized clinical trials, where you don't have to have people come into a hospital setting to undergo the trial. They can be at home depending on what the trial is for. And the other one is things like efficacy of medications, right? So if you understand the impact on the body on day one, well, what does it look like on day 15? What does it look like on day 30? To really understand sort of in that real-time data element of what the impact of the clinical trial drug or whatever they're trying to prove out, using our system as a conduit to collect that in real time, either remotely or on site.
Yeah, I love those ideas. In fact, in the last few minutes that we have left, Terry, I'd love for you to kind of like summarize. How do you tell someone that it's okay to get started? What does that initial few weeks look like for you guys as far as advice that you would give to one of your colleagues that are in the audience here? And Todd, would love for you to do the same thing after Terry. How do you tell people it's okay to get started, and here's what your experience will look like when you get started?
Yeah, I think you have to start with a clear vision, right? What are we trying to solve for? Because it has to be real. People, when people say, what am I going to do with this data? It's because it's personal, change is personal to them, and they don't want it to impact them in a negative way. So we have to start with a clear vision. I think engaging the stakeholders early and some of the things that Todd had talked about, all definitely part of the change management. This is although I manage IT, this is not an IT project. It needs to be a clinically driven project. Or if you're using, similarly for the business side. I also think, you have to learn fast. You have to hear their concerns, you have to listen, and you have to learn fast and make course adjustments, because you have particularly something new like this that has a little bit of fear base to the risk level of it. You have to be able to adjust and show that I'm listening and I'm not just going to implement and walk away. Because, it's at the end of the day, it's people's lives that we're impacting, and a lot of people who don't want to change and the way that they're caring for patients is because they don't want that responsibility of maybe doing harm, right? And so that you do have to take that into consideration. I think, if you have those elements, people, and obviously do a pilot so that you can shout out all your successes, be honest about your failures, and kind of walk through that. But I think that people will typically come on board when they see how it impacts them, when they see how it impacts their patients. We're all in healthcare to care for patients. We're not in healthcare to make a bunch of money. And so I think that's we have to hit them where their heart is, and show them the value of it. And it starts out with those kind of key elements.
Mm-hmm. And has your automation journey so far been worth it?
Oh, absolutely. I'm very passionate about it. I can talk about it for for many, many hours. I think this is probably the funnest part of my job, and the hardest. I think, just that change management can be definitely hard. But, I've had providers that were in my office every day screaming how it wasn't going to work. It wasn't going to work. It wasn't going to work. And I'd start off with, what part of this can you get on board with, and let's go from there. And now they're our biggest champions, right? And so it is working together hand in hand. My goal is to make sure that nurses still want to care for patients, that we have a nursing staff here, a nursing complement, and that we're not using travelers. I still want our patients to be able to be cared for where they want to, because that's what I want. And for me, my neighbors, my family, and so we definitely have seen the successes. But it's not always easy, but it is definitely exciting, and it does give a lot of satisfaction when you see it work.
Awesome. So Todd, in the last couple of minutes that we have, tell us a little bit about how you would advise change management. What should that initial experience look like? And based on your learnings, would you adjust anything as you go forward?
Yeah. First off, I think Terry gave an amazing summary. I agree with pretty much everything that she said, and in the route that she said. So what I would really try to focus on is knowing your organization and how, whether it's the mood, the feel, adaptivity, all of those things, know your organization and how the use of products like this or other related products, how do they tie to your vision? How do they tie to your mission? And how is it that you want to roll them out? So our gap and our use cases did not come from me. I'm, for lack of a better term, the business project manager on this, right? I'm running it from the innovation lab side. I'm removing barriers. I'm getting workflows. I'm getting, bringing the IT team in. I'm bringing legal in and contracting. So, right, I'm doing all those things so that the clinical staff does not have to deal with any of that. They're really focused on our mission, which is providing the best care. And what this is doing is helping them bring the joy of medicine back. You're really focusing on the patient. So I really love what Terry said, but I would even build a little bit, build that wall a little higher to say the goal is to bring your care cases not from the IT side, not from the business side. The care cases need to come from those on the floor. Go to them and say, hey, I think this is a really cool device. This is a really cool project, really cool program, whatever the setting, and say, how does this fit? Where does it fit? What are your thoughts? Brainstorm, open session. So I think you really have to focus on making sure that your use cases are coming from those so that the use cases are useful and that the use cases are meaningful, and involve the staff. And in listening to Terry's wrap up, I'm going to use the word she used repeatedly, and I agree with that 100%. And that is our role in this, in rolling these out in change management, is listen. We have to listen to the staff. We have to be nimble. We have to be adaptive, and it's an iterative process. And you can't have that without listening. So I would wrap up with really those three things. Your use cases have to come from those involved in the field every day. Make sure it ties to your vision and mission, and then listen as you're working through this as an iterative process.
Awesome. Well, thank you so much, everybody. We're out of time. We go so fast. Terry, awesome advice. And I see your RN sticker. So you're one of those folks that Todd was mentioning. Super brilliant and getting around things when something gets in your way. So thank you for everything that you guys do. Todd, really appreciate it. Joe, thanks for getting us all together. And I'll hand that back to Carol now.
Conversation. I'm going to just read a brief disclaimer before we move into our next session, which is the Natera 130H plus vital sign monitoring sensor is an FDA 510K Class 2 medical device cleared for spot and continuous measurement of heart rate, respiration rate, and behavioral features in adult patients within healthcare facilities and home use. The indications provided are to be used by healthcare professionals and are intended to be reviewed by clinicians to inform on patient care. The Natera monitoring system is not intended to be used as an alarm system for potentially life-threatening situations in which medical intervention is necessary. This webinar may include discussion on future device features. For further details on its current applications, please visit www.natera.com.